Acquired infections in pediatric and neonatal intensive care units represent a formidable challenge in modern critical care. These infections emerge in the most vulnerable patients, often as an unintended consequence of life-sustaining interventions. Their prevention demands a delicate balance between technological advancement, meticulous infection control, and vigilant clinical practice. Here to enlighten all of us on this subject is our esteemed panel. The moderator for the panel discussion is Dr. Sanjeevani Masavkar. Ma'am is Additional Professor, Department of Pediatrics and the in charge of PICU and Pediatric Cardiology Services at LTMGH. She is also a member of Mumbai Critical Care. I would kindly invite all our panelists to the stage, Dr. Ira Shah, Dr. Swati Manerkar, and Dr. Mandar Zamdar. Dr. Ira Shah heads the Department of Pediatric Infectious Diseases as well as the Pediatric GI and Hepatology Department at Wadia Hospital, Mumbai. Ma'am is also the Nodal Officer of the Pediatric Drug-Resistant TB and the ART Center there. Dr. Swati Manerkar is Professor and Head of Neonatology at LTMGH and in charge of the Zonal Reference Center for Human Milk Banking and the Comprehensive Lactation Management Center. Dr. Mandar Zamdar heads the Pediatric Critical Care Department at MRR Hospital, Thane. Sir is also a teacher as well as an examiner of the IAP Critical Care and Emergency Fellowship courses. Welcome all. Over to you, ma'am.
Thank you, Bhuvaneshwari. Good morning, delegates, seniors, and panelists. Welcome to this year's DAFPAL CME 2025. Our theme today is Unintended Afflictions of ICU Care, Acquired Infections in Pediatrics and Neonatology. We have with us three esteemed panelists, Dr. Ira Shah, Dr. Swati Manerkar, and Dr. Mandar Jamdar. And I am Dr. Sanjeevani Masavkar, your moderator for this session. Together, we will all walk you through real cases, essential principles in managing healthcare-associated infections in critically ill neonates and children. Healthcare-associated infections continues to be a major global concern, and with increasing complexity in ICU care, hospital-acquired infections significantly impact morbidity, mortality, length of stay, and hospital resources. Our goal today is to understand how these infections happen, how to identify them early, and how to prevent them effectively. Hospital-acquired infections is by definition, they are new infections occurring 48 hours after admission and even after discharge. The most common ones are in our unit, that is VAP, catheter-related bloodstream infections, and catheter-associated UTIs. So we are going to start with our first case. We will explore this through a case discussion. Let's begin our first case. A 3-year-old female who was referred with fever, cough, breathlessness, and then patient had on examination tachypnea, subcostal intercostal retractions, CREPS, saturation was not maintaining on room air, required NRBM, and patient was having tachycardia, patient was lethargic, had fever. So patient was intubated and IV line secured, supportive care were given. Point of care labs were sent. So provisional diagnosis of community-acquired pneumonia was made, and empiric antibiotics like ceftriaxone, vanco, and azithro was started. So a patient then had all the blood cultures and all were awaited. Respiratory biofires were sent. Blood culture showed no growth. Respiratory biofires were mycoplasma pneumonia. Then vancomycin was stopped and ceftriaxone and azithromycin continued. Response to antibiotics was seen, and patient had ventilatory settings which were decreasing. Patient was about to wean on SIMV. Ventilator and SIMV trial was started. But on day 5, patient had new onset fever, new consolidation, purulent white ET secretions, worsening blood gases, leukopenia and CRP was on rise. So what is the most probable cause of this new onset worsening? Dr. Mandar, can you throw light on this?
Good morning, everyone. So here we are on the day 5 of illness, and considering the reports of BioFire, we have stopped vancomycin and we are continuing with other antibiotics. So I would like to give it a thought here that whether it was a gram positive, which was a co-infection which was there, probably that has kind of come back. But if you see the complete picture, there is a new consolidation and the ET secretion which were not purulent are there, and increase in ventilator settings as well as worsening of your gases in terms of the oxygenation indices. So here, of course, we would like to give it a thought as a hospital-acquired infection in terms of ventilator-associated pneumonia. We would like to consider.
So, Mandar, can you tell us, is there how to diagnose this hospital-acquired pneumonia or ventilated-associated pneumonia? Is there any criteria for that?
So theoretically speaking, there are several criterias which are there mentioned in literature. But as far as clinical practice is concerned, you should always have this in mind that any child who is on ventilator, who is sick at presentation, having a prolonged ventilation stay, and requiring inotropic support these are the potential candidates or the children who are likely to develop ventilator-associated pneumonia. You should not wait for these sick kind of factors which are mentioned in the books that they should be kind of completely tick box, so that only we think about VAP. Any child who is on ventilator, we should always take utmost precaution, and our unit practices and the guidelines should be like that we take all the measures to prevent VAP. If I have to mention few factors like prolonged ventilation, the book says more than 48 hours, having fever, high counts, even the low counts, and new worsening radiologically. Though we don't wait for the radiological picture to come up, there are subtle indicators like worsening of oxygenation, increase of ventilator parameter, even the change in ET secretion. These are the kind of things which we use to diagnose or to suspect. And of course, we should take every attempt to prove it by culture. So microbiologically, whatever samples you can think of, whether it's a ET aspirate, mini ball, or invasive ball, which is not suggested, but these are the modalities which we can use to prove the microbiology, and that will kind of give you an idea whether you are dealing with VAP or not.
So our patient has fulfilled all the criteria which is displayed and told by Mandar. So Mandar, can you tell us, are there any risk factors which are responsible for causing VAP in children?
So again, the sickness with which the child comes to ICU, I mean every child coming to ICU is of course sicker compared to those in the ward or those having the walking pneumonia or community acquired pneumonia. So any child who is sick enough to come to ICU, having hemodynamic compromise, requiring prolonged ventilation, or the pneumonia going into further complication like acute respiratory distress syndrome, these are the subsets where we kind of think that this is a candidate who can develop VAP. Any child who is on immunosuppression, again that modality is the one who is a candidate or the kind of risk factor to develop a VAP.
So these are the risk factors which Mandar has told us regarding in children. Now, Dr. Swati, can you tell us, and when do you give MRSA coverage for VAP, Mandar?
So by and large, the VAP organism usually is GNB. You should have your unit prevalence, if at all, that you should know your incidence of MRSA and you can give coverage. But by and large, the VAP usually is a gram-negative organism. MRSA is not very common. But again, the sickness of presentation, if I have to say, the prior use of antibiotics, and a child who is sick enough and high risk of mortality, we can cover, send cultures, be empirical initially, and then you can de-escalate depending on your culture reports and the response to treatment.
Thank you, Mandar. Swati, can you tell us some risk factors in neonates?
So neonates happen to be a slightly different population because most of the guidelines, most of the recommendations have been adapted from adults and children. If you talk about newborns, the smaller the baby, the more premature the baby, The baby remains at a risk right at birth to develop any infection. Then, of course, prolonged intubation, prolonged stay in the hospital itself, recurrent extubations, unplanned extubations, re-intubations, even one gap in maintenance of asepsis during suctioning of the baby, unintended suctions. So it's recommended that suction is done only when the baby shows visible secretions in the ET, not otherwise. All of these will contribute to development of VAP. In addition, exposure to broad spectrum antibiotics will completely change the flora, and we will see emergence of more of hospital-acquired infections. In addition to that, presence of the nasogastric tube itself will keep the gastroesophageal sphincter lax, and that can lead to microaspirations. Larger feed volume could mean microaspirations. Then use of proton pump inhibitors would change the gastric acidity and again make the baby more susceptible to developing a VAP. Also, use of steroids will further suppress the already existing suppressed immunity, and all of these factors will lead to an increased incidence of VAP.
Thank you, Swati. Which are the common organisms causing VAP? Dr. Ira Shah, can you tell?
I think Mandar already said, basically it's going to be your GNBs, the gram-negative bacteria. So your Klebsiella, your Pseudomonas, Acinetobacter, Stenotropho maltophilia, all these are the ones that you will usually cause VAP.
So which antibiotics you start empirically and then how do you change?
So one is you need to know your antibiogram of what is prevalent in the ICU at that time. So depending on the bugs that you estimate the child may be having based on your last month's antibiogram. So you see the antibiogram, you know which are the bugs prevalent in the ICU, you know their sensitivity pattern, and then you will decide on the antibiotic that you want to give. Say for example at Wadia, for the NICU, we have our first line antibiotics, which every NICU will be having Ampigenta. But the second line is actually decided on the previous month's antibiogram. So if we had a Burkholderia outbreak or we had a Klebsiella outbreak, the second line immediately changes. So depending on what's there in your ICU facility, which bugs are prevalent at that particular moment in time, you will decide on the antibiotics.
So what is the significant growth versus colonization? Dr. Mandar?
So it depends on what method of sampling you are using, whether it is a non-invasive to invasive. So if you are using just an AT aspirate, of course it is a least invasive technique, so your cutoff is little on higher side, which is 10⁵ CFU per ml. If you are going for a mini ball, then it is 10⁵ to 4, and for ball it is 10⁵. So depending on what modality you are using, your significance growth and the colonization you can define. Apart from that, also you need to understand that if the child, like in this particular case, it's a day 5 of ventilation, the tube is in place for 5 days. And if I am going to do just an AT aspirate, which is like passing a suction catheter and getting a sample from AT tube, it is very high chance that this tube is already colonized with something. So that is where I have to analyze my culture report with a lot of thoughts, whether I can do the tube-in-tube culture which we follow. It is possible in older children, like those who are having maybe above 4.5 or 5 size AT tube, where you put a suction catheter, and again within that you put another suction catheter for sampling. So the catheter which is used for sampling is not coming in contact with your AT tube. So the chances of whatever growth comes, whether it's a colonizer, that chances goes down. So that you have to understand, and the cutoff which I have already said, depending on what method of sampling you are using.
Okay. So what is an antibiogram?
Yeah, so as I said, you look at the antibiogram. So in your ICU, say in the last 1 month, you had 15 cases of Pseudomonas, you had 5 cases of Klebsiella, you had some E. coli. You remove the sensitivity pattern of each bug that you had in percentage wise. So for each antibiotic, you'll have a sensitivity pattern, and you will know whether you have carbapenems, whether you have CREs, whether you have ESBLs. You come to know from your antibiogram as per your percentage. And depending on that, you know what's your choice of antibiotic.
So do you have antibiogram for your ICU, Dr. Mandar, Dr. Swati?
So we generally follow a first line empirical as augmentin amikacin. The next step up, second line is piperacillin tazobactam with amikacin. The third line would be meropenem amikacin, and beyond that it's usually more culture driven depending on what growth is found in the samples.
Mandar?
So we are just a 2-year-old hospital, the MRR children. So we have our antibiogram where the hospital acquired infections, as madam also has said, it's mainly gram negative bugs. And the resistance pattern around, so far around 30-40% are more of a CREs which we have come across. So again, while deciding which antibiotic to start, depends on what antibiotic child is on and on which the child has worsened. So you kind of think and go beyond that.
Can I add something
Yeah,
here? Yeah, so I think all hospitals now should have audit of the antibiotics and the audit of the microbes that you're seeing in your this thing. Because what we are seeing is most of our organisms are actually carbapenem resistant. They are mostly piperacillin tazobactam resistant. So to have a second line based on empirical that this is going, you will need an antibiogram to decide on your second line. Otherwise, you're going to have a long hospital stay, lot of morbidity, and a lot of unnecessary broad spectrum drugs that will go on, which will ultimately lead you to a stage where you don't know what to give.
Also, the ET cultures through EMBAL, paired blood culture, urine culture were sent, antibiotics were upgraded according to hospital antibiogram. Blood culture, urine culture showed no growth. ET strain shows GNB, and purulent aspirate acinato, ET culture showed Acinetobacter baumannii species. And Dr. Mandar, can you tell how to decide the dose, route, de-escalation and escalation?
So here the child was on. Ceftriaxone, vancomycin we have stopped, and the organism which has come as Acinetobacter baumannii, which is the resistance pattern. If you can see, though there are no MIC mentioned, but it is sensitive to TG cycline, and meropenem it is not meropenem the MIC I cannot see, so it's not mentioned. So you try to be initially when the child is sick and worsening, you try to be more empirical. So the merocolistin which is there, that you can think of. You can consider here meropenem infusion also. Again, it depends on, so the way we approach, I mean, it's not the one line answer, what dose and what antibiotic. So what antibiotic it is resistant to, what is the MIC for that antibiotic, and if at all you have an access to the genetics test which we are doing, the Carba Expert, which again gives you the what pattern of GNB resistance it is. So that tells you which antibiotic to choose, whether to give meropenem as an extended infusion or to go beyond the meropenem. So it all depends on that. Madam wants to add.
Yeah, can I
Dr.
just go
sorry,
back to
sorry.
that? Yeah, I'll come to that clinical breakpoint. Now, if you look at this report, which has your MIC and your breakpoint. So MIC is what your organism was on the culture, and in vitro, you're looking at the minimum inhibitory concentration that is required to stop the growth of that bug. So that is varying from patient to patient. Whereas breakpoint is determined by the CLSI or the UCAST guidelines, which is organism specific. So this is a breakpoint at which these antibiotics will not work. So beyond this, beyond 8, it will not work. So if you look at the breakpoint of minocycline, you have an MIC of 16 and breakpoint of 8. So if you look at 8 is the breakpoint, beyond this, no minocycline is not going to work for this patient. So if you look at TG cycline, now TG cycline is 4 and breakpoint is 8. So that's why they've shown it as sensitive. So anything beyond the breakpoint is considered as resistant. Anything below the breakpoint is considered as sensitive. Now when you look at this antibiogram, you can see that, not the antibiogram, you look at the sensitivity. You're looking at meropenem. So meropenem, what you're seeing is resistant. They've not given us the breakpoints or the MIC. Breakpoint of meropenem is 16. But with a report of MIC of 8, they may say it is resistant. So you have to look at the latest CLSI guidelines, which come out every Jan, and know what are the breakpoints. So you have to keep on going back and referring to the breakpoints. Now, you have a child who's on meropenem colistin. You have a child who's got a CRAB. This is known as CRAB, carbapenem resistant Acinetobacter baumannii. and carbapenem is not going to work in this child. So you have to decide on an antibiotic which will work for Acinetobacter. The commonest antibiotic that works is sulbactam. We don't have any, we have got a cephalosporin sulbactam, but we don't have, for high sulbactam, they've not given an MIC. So we have to go according to this limited information that we have. So looking at this report, anyone will say, okay, let's give tigecycline colistin. Okay, because colistin is intermediate and tigecycline is working. Now you look at the PKPD. So you want that antibiotic to go into the lung. So you want to know which antibiotic will go into the lung. Colistin is not very good for lungs. So in fact, you prefer polymyxin. So depending on the PKPD, you know that polymyxin is a better drug. Tigecycline, again, you look at the synergy and the mechanism of action. Where does it work? So tigecycline is working on the ribosomes. You have colistin, which is working on the cell wall. Okay, synergy will work. So that's how you decide on your antibiotic. So if you have this patient where you don't know the sulbactam combination, you may go on to colistin and probably minocycline and not tigecycline, because though minocycline is showing resistance, but it's the same group. But your tigecycline, but lung penetration is not very good.
So Dr. Irasha has already explained what is MIC and what is clinical breakpoint. So what do you mean by sensitivity, intermediate sensitivity and resistance?
So I already mentioned that when your MIC is less than the break point, then you know it's sensitive. When your MIC is more than the break point, you know it is resistant. And as I said, meropenem, sometimes they may report as 8 as resistant, but it may still be intermediate sensitive.
So coming to prevention, what is the bundle approach for prevention of VAP, as VAP is always preventable?
So every unit should have a VAP bundle, and that should be followed very strictly. Though, as I said in the beginning also, that there are criteria to identify which kind of patients are the kind of subset to get or to develop VAP, but for every child who is on ventilator, this bundle should be followed. So it starts with, of course, hand hygiene in the ICUs, head and elevation, the PPI which was there initially, now that has been removed. So the proton pump inhibitors which was there as a bundle of VAP, that is not followed now, because it had shown that it reduces the acidity and kind of further enhances and supports the colonization. And of course infection. Oral care is very important. There are, there is evidence which is coming up against following the oral care with chlorhexidine. I am not sure what is the practice in NICU, but in pediatric ICU we do daily mouth care with 2%, 0.2% chlorhexidine. That is still being followed. There are certain papers which has come up recently which is showing that it is not showing benefit RCTs, but it is not as of now come as a recommendation. So that is still a practice in many of the standard units. Ventilator circuit, most important. There is a lot of condensate which happens, which we see. So that should be drained away from the patient, that you need to taken care of. Nowadays the practice is we put always a cuff tube. Cuff pressure monitoring has to happen. You have to also ensure that the tracheal injury is not happening, so kind of deflate the cuff your ventilator settings are allowing for at least 15-20 minutes. Inflate it, try to maintain the pressure between around 15 to 20 so that you are not injuring the subglottic part, which is the narrowest part of your airway. And daily assessment of sedation, whether it is needed, whether you can allow the sedation holiday, avoiding paralytics. Absolutely, unless you are dealing with a very high ventilator setting child who is on prone ventilation, ARDS, those are the candidates where we kind of give neuromuscular blockade, that too with following the holiday, but not as a routine blanket, starting the child on neuromuscular blockade and kind of knocking it off completely. And of course, daily assessment whether the ventilation needs to be continued, when I can start weaning at the earliest, that should be followed. So this is the bundle approach. Every shift, every doctor and nurse should kind of go through it and ensure that this is being followed, and that's the standard practice.
So is it same for NICU, Dr. Swati? Can you throw light?
So a lot of it remains the same, but there are few things which could be done in addition, if you could just pull out the points. So head elevation is very crucial. We do not use cuffed endotracheal tubes in babies, so the risk of microaspiration always remains. It's important that oral secretions are cleared out. Oral suctioning periodically. ET suctioning, however, should be done only when secretions are visible. Colostrum oral immune therapy is a very effective measure to reduce the incidence of VAP. So in the first 72 hours, if we can manage to get the mother to express colostrum and trickle a drop or two, about 0.5 ml in both the cheeks, that has been evidence-wise shown to be effective for prevention of VAP. Always err towards non-invasive strategies and aseptic techniques for suctioning. In addition, very important to have ongoing staff training and always at every round, every contact with the patient, evaluate whether the patient is ready for an extubation and scale down to a non-invasive strategy.
So applying this consistently significantly reduces VAP rate. The child improved on tigecycline colistin, child responded well, decrease in fever, improvement, ventilation parameters extubated on day 14, and then a child was stopped after 14 days of TG colistin.
So before-
this case highlights the importance of early culture, correct de-escalation and adherence to VAP bundles. Coming to our second
Just
case.
one point, yeah.
Yes.
Now, one point that I wanted to highlight, which all of us can do here, is when we send cultures, we get a report after, say, 48 hours. We'll get a flash in 24 hours. We'll get a report after 48 hours. We'll get a DST. Probably it will take 72 hours. So you're losing precious time for next 3 to 4 days. What I would suggest, all the hospitals have a gene expert machine, all the municipal hospitals. You have a gene expert machine. Ask your microbiology to get a Carba Expert cartridge. So we have an MTB cartridge. You ask your hospital to get a Carba Expert cartridge. Whenever your culture grows a flash, that is in 24 hours, do a Carba Expert on that, because what we are facing in Mumbai is carbapenem resistant. So you will come to know your genotypic, whether it is NDM, whether it is VIM, whether it is OXA48, you'll come to know in that 24 hours. And depending on your which resistance it is, VIM, OXA48 or NDM, you know your second line. So you don't really need to wait that long for 72 hours for your culture DST to come. You will have a report, and it's not very expensive. The cartridge would be around 1,500 or 2,000. So it turns out to be much cheaper.
Actually, IIT also has come with Inflex, some genomic studies in microorganisms, which gives a qualitative resistant pattern.
Yeah, but this is inbuilt into your gene expert machine. So you don't need to buy anything extra. You just need to have a cartridge. Second is your biofire.
Yeah.
Now, when you do your biofire, especially when you send a respiratory sample, there are two types of biofires that are available. One is respiratory, which they take a nasopharyngeal aspirate. That is more for your community-acquired viral infections. Second is a pneumonia panel, which is done on your intubated patients or on a bronchoscopy sample. Your biofire also gives you all these AMC, it will give you ESBL, it will give you carbapenemases, everything. It will give you a genotype. But a biofire is going to cost you very expensive, so 20 to 30,000. So Carba becomes easier to do rather than a biofire. But if you have a setup where you want to do a biofire, in a hospital-acquired infection with a VAP, send a pneumonia panel, not the nasopharyngeal aspirate.
Thank you, Dr. Ira. So now going to second case. This is a 27.4 weeks gestational age female child born to a Gravida 2 mother with leaking PV for 16 hours with no foul-smelling discharge, received 1 dose of beta-methasone peptase, and child was 860 grammer and had distress managed on SIPV, synchronized IPPV, and received 1 dose of porcine surfactant, extubated 72 hours on nasal CPAP, and on day 6, initial septic screen was negative. Hemodynamically, child was stable and was started on TPN, received gradually increasing feeds, good skin care, PDA was managed. And on day of 8, baby developed multiple episodes of apnea requiring positive pressure ventilation, intubated on AC mode. Baby developed metabolic acidosis, shock, and low platelets. So what do you suspect, Dr. Swati?
So here, I would think of either an infective or a non-infective problem. This could very well be bloodstream infection because the baby is very small, 8 days, and is receiving IV therapy. Similar presentations can also be seen if the baby develops an IVH and can have respiratory problems and secondarily starts going into acidosis shock. However, the low platelets does not explain it. Even if the baby starts developing some kind of a enterocolitis, though it's very early for a necrotizing enterocolitis, he would present with a very similar presentation.
So which investigations you will ask for this baby?
So a sepsis workup, of course, which would be a CBC, ANC counts, differential count, IT ratio, send off the cultures, get a CSF to rule out meningitis, get an X-ray to look for any infiltrates in the chest or anything in the abdomen. Along with this, if any of these starts, a CRP, of course, procalcitonin if there is a facility, and then according to the results available, the treatment would be planned.
So all the investigations were done, and patient had leukopenia with ANC, which is low platelets, CRP was high, and CSF was showing cells. And there was culture which was sent, which was showing Klebsiella pneumonia sensitive to meropenem colistin, resistant to penicillins and cephalosporins. So what do you mean by, Dr. Ira, can you tell us what do you mean by central line associated BSI or CRBSI?
Yeah, so when you have a blood culture positive and you have a central line inside, you may think that this blood culture is positive because of the catheter, okay? But it can be not associated because of the catheter, not because of the central line. When you call it that the central line is the cause of the bloodstream infection, is when you have a growth, you send a paired culture, you send one from the central line, one from the peripheral blood. Both are growing the same organism. The organism from the catheter site is growing earlier as compared to the peripheral blood, so it is around 2 hours earlier. Or you have a growth, which is 5 times higher, which your lab will not give you. So the only way that you come to know practically is the growth time. So you ask the lab which grew first, how many hours earlier. So if your catheter growth grew first, then you say this is a Klebsiella. Otherwise, you will just say it's a bloodstream infection.
So as Klebsiella is surveillance definition, positive blood culture, central line present, no other focus, and BSI, proven catheter source, differential to time to positivity, and matching organism. Coming to risk factors, which are the risk factors responsible for BSI in NICU? Dr.
So again, the smaller the baby, the more premature the baby, the risk goes higher. The longer the catheters are in, the risk goes higher. The more time it takes to build up on feeds, the risk goes higher. And in general, a longer stay in the hospital would mean the baby is exposed to more invasive procedures, and that way the risk is higher. Exposure to broad spectrum antibiotics early on would also increase the baby's risk for developing resistant sepsis or even fungal sepsis.
In pediatrics, what are the risk factors responsible for BSI?
So addition to what already mentioned, in pediatrics, again, the sickness, the duration, all those things are there. But the even the site of line, where the line is, whether it is in the femoral, subclavian or IJV, these are the 3 common sites which we are put in pediatric population. So femoral has been shown to kind of associated with more BSI, of course related to closer to the coming in contact with the urine and stool, so GNB infection. So IJV and subclavian, the site of line is one thing that we have to keep in mind. Number of lumens of the catheter also is one other risk factor. If you have a single lumen, double lumen or triple lumen, and any hospital acquired, whether it is Klebsiella or VAP, which I have not mentioned in the previous discussion, how busy your unit is. If I have only 1 or 2 patients and 1:1 nursing ratio, of course the risk factors, even if there is a femoral line, the chances of having Klebsiella comes down, whether I am in a busy unit where I have 10 patients and shortage of nurses like what you have in Sion and Vadia. So of course the human factor, the manpower, that is another important factor which we should consider apart from the patient factors.
So, Dr. Irasha, can you tell us which are the organisms which are responsible for BSI?
So basically, when you have a Klebsiella, then your gram-positive organisms start coming into the picture. So you think of corns, you think of MRSA, Enterococcus comes. Your GNBs are prevalent throughout. So your GNBs remain, your Serratia comes into the picture. So all these are the organisms. In neonates, especially what we've seen is your Candida comes into the picture. And you could have Candida parasilosis, tropicalis, or auris. Nowadays, we see a lot of auris. So in neonates especially, this is what we see.
So, what are MDROs? What kind of common resistant patterns seen in hospital-acquired bugs? Dr.
So
Ira?
you have different organisms with different resistance patterns. Say, for example, a GNB. Let's take simple E. coli. Your E. coli can be resistant because of beta-lactamases. So your beta-lactamases can be AMC or your ESBL. They can become resistant due to carbapinamases. So that can be your carbapenem resistant. Then they can, depending on so it's either enzyme related, so ESBL or your carbapinamases. It can be efflux. Your antibiotic may go inside, but there are efflux mechanisms which push out the antibiotic back. So it doesn't work. So even though it's sensitive, sometimes you wonder why it's not working. You're giving a sensitive antibiotic, but still the patient is deteriorating. And that's when you think of efflux mechanisms. So efflux mechanisms come into the picture. Then you have these mutations in the DNA, like say, if you have a fluoroquinolone resistance, so it's a gyrase mutation. If you have an MRSA, then you think of a MEK-A mutation. Vancomycin, then you think of a VAN-A, VAN-B mutation. So depending on that.
So, what is AMC and carbapenem resistance pattern?
So AMC enterobacteria is basically your beta-lactamases will not work. So your all your cephalosporins, penicillins will not work. Carbapenem resistant enterobacteria, basically your carbapenems will not be working. ESBL, your third generation or fourth generation cephalosporins will not be working. Your first and second generation may still work.
So, this is the resistant pattern and useful antibiotics which we should use. What is the WAP bundle? Can you tell us what is the approach? See, if there is a child who is febrile with CVL and worsening shock, so Mandar, what you can do? Means what is the antibiotic lock and whether you will take out the line or not?
So, child in ICU who is febrile, CVL in place, and my shock is worsening. So, I will see this from the two perspectives. Whether the child has just come in shock and I am placing a line now and the child is worsening, then of course it is an ongoing process which I have to kind of deal with. Secondary is child has been in the ICU and now has started with new onset fever, which probably is the question is. There is a CVL in place and the shock is worsening, which is, I assume it is new onset. So here, again, what antibiotic child is on, that I will first see and try to kind of upgrade the antibiotic empirically and send the culture. So when I am sending the culture, the approach, so paired culture, there is a misconception, like if I have a triple lumen, I am sending a culture from the two lumens, that is not right. When I say paired culture means one sample has to be from the center line, preferably the distal port, and one sample has to be the pricked, which is kind of collected peripherally. So that is the definition of paired culture and not the double lumen, triple lumen, where you are kind of sending two culture set of bottles. So I will send the paired culture, I will upgrade the antibiotic, and we'll see, depending on the clinical situation, how the subset of patient is, whether to remove the line or not, that will be the next. But immediately jumping and removing the line is usually not done. We'll try to salvage it as much as possible. So
What
that
about
is the general
antibiotic
approach.
lock, Dr. Ira?
Yeah, so as Mandar said, we try to salvage the central line because we can't be putting new central lines all the time. So if you've grown a GNB, then you want to salvage the line. When will you remove the line? First instance is when you have Candida. Candida forms a biofilm. So organisms that form biofilm, you know nothing is going to work. So Candida, if you've grown, you have to remove the line. If you've grown a GNB, you try to salvage the line. Now, when you're trying to salvage the line, there is a biofilm formation into the catheter. So by giving a very high dose of your antibiotic, usually we used to give gentamicin lock. So for GNBs, you give gentamicin lock. Say if you've got MRSA, you may give a vancomycin lock. So when you give a lock, you inject around 1 to 2 ml of that particular antibiotic. The concentration has to be 1,000 times the MIC of that bug. So you make it that way. You have to make it very concentrated. So you have these protocols, various, you just need to download those protocols. So you make that solution, inject 2 ml, keep it indwelling into that catheter port for around 12 hours. So that antibiotic is working locally. You remove the antibiotic after 12 hours. So don't inject it, don't flush it. Okay, otherwise you're going to have a problem. So you need to remove that antibiotic 2 ml, whatever you've injected after 12 hours. Again, prepare a fresh solution and again inject. So you are keeping that port as an antibiotic lock. Maybe you will be able to salvage your central line. But if you have some infection at the port, you are seeing a tunnel infection or you are seeing an exit site infection, then your antibiotic lock is not going to work.
So this we have done. What is the duration of antibiotics? How do you decide about the duration?
A lot of factors. It's not one factor. One is the bug that you have. So if you have GNBs, the age of the patient, if it's a preterm GNB, then what are the other sites of infections that the patient is having? Like your patient has gaseous distension of the bowels, so probably there's an NEC, there's a meningitis. So depending on all sites of infections, on an average, you would be giving something like 14 to 21 days is what your duration.
So can you just throw light on insertion bundle and maintenance, Dr.
So
Swati?
these are very important practices which we need to incorporate into our daily practice. Insertion bundle would mean there is a dedicated cart for central line insertions. Hand hygiene has to be emphasized at every point. Maximum barrier precautions need to be taken. Skin should be disinfected with a proper antiseptic solution. In children more than 2 months, chlorhexidine could be permissible, but in smaller babies, preterm babies, there still is a controversy with using chlorhexidine. And to cover the insertion site with a transparent semi-permeable dressing so that it's visible all the time when we check during the maintenance, when we look at the maintenance bundle. In the maintenance bundle, it's important that every day we assess for whether the line is required or whether the line can be pulled out. So that's very important to reduce the duration of the catheter inside the body. Again, hand hygiene comes in. Assessing the catheter site for any ooze, leakage, or any other dysfunction. Also, the scrub the hub technique is very crucial. So 15 seconds of scrubbing the hub and 15 seconds waiting for the disinfectant to dry is important so that we don't flush in any organisms. Even one slip in this scrub the hub could mean a disaster.
So this baby was improved with prompt escalation, line change, supportive care, and completed antibiotics, and she was discharged on day 42. Now we will not take 40 because we are short of time. So the take-home message is maintain a high index of suspicion of HAI. Send appropriate cultures before initiating empiric antibiotics. Escalate, de-escalate antibiotics based on microbial identification. Treat resistant bugs, organisms align with the antibiogram. Choose the right drug and combination. Prioritize prevention. Hand hygiene remains the single most effective intervention. Hospital Infection Control Committee and robust institutional policies with active surveillance are essential pillars of hospital management. Thank you, our panelists, and Dr. Ira, Dr. Swati, Dr. Mandar. Thank you, Dr. Omkar, Dr. Radhika, and Riya for helping me in this presentation. And thank you, audience, for your kind attention. We hope this session empowers to reduce the hospital-acquired infection burden in your units and improves the outcome. Thank you.
Thank you all for your valuable insights. I would request Dr. Sujata Sharma to present the moderator and our panelists with a token of appreciation. I request you all to wait for a group photo. Thank you all.